And at this point, I would like to thank our sponsors. An event of this size cannot happen without the support of the sponsors. Our gold sponsors, Messrs. Bosch and Messrs. Sundaram Clayton Limited. Our silver sponsor, Tata Power DDL. And our sponsors, Messrs. Aether, Kauvery Hospital, Rolleiflex, SEG Automotive, TQMI, and Rajas. Thank you. Thank you. Enjoyed your lunch. Okay. And to make the post-lunch session more enjoyable, we have a varied pack of sessions and other format of interactions, okay, which is taking TQM beyond the manufacturing sector, was talked about in the morning, and also about taking TQM to the next generation was discussed about. So how are we going to make all it happen? To give us some inputs on their experiences, we are having some excellent sessions in this particular session. To chair this session, may I request Mrs. Sarika Joshi to come on stage. She is the president of the Pune chapter. Please put your hands together and welcome Sarika.
Nandri, Mr. Sundarajan, and Malay Vanakkam. In my native language, there is a proverb by one of the great saints that whenever there is a gathering of saints at home, it's the time of festival. And I think as a quality professional, for me and for you all, this is no less than a festival because we have a gathering of such an eminent speakers around the globe and such great expertise in the quality professional, quality gurus who have come together in one single, forum, and thanks to ISQ for that. So we have one session. Till now we have listened to the great quality gurus and quality expertise. Now we have a session from somebody who is having a real noble profession, Dr. Manivannan Selvaraj. He is managing director and DnB. He is founder and managing director of Kauvery group of hospitals. May I request Dr. Manivannan Selvaraj to be on the stage. I'll read out his introduction. I'll introduce him. He's a well-known medical entrepreneur, pursued his MBBS degree at prestigious Madras Medical College in the year of 1992, and MD in anesthesiology at BJ Medical College, Pune in the year 1997. He's the first generation doctor in his family and is married to Dr. N. Suchitra, who is also MBBS, DGO, and a leading OBGYN. They are both blessed with a son and a daughter. He's the founder and managing director of Kauvery Hospital, which is a leading hospital in Chennai. We started in the year 1999 as 3-bedded hospital with the mission of making great healthcare affordable. Now it's a 3,000 plus bed hospital in Tamil Nadu in 6 cities with 8 units with an average of 843 crore turnover per year. Kauvery Hospital has established more than 32 occupational health centers concerning the need of industrial health. He is the founder and managing director of Medical India's largest medical equipment exhibition since 2006. He is also managing director of Agile Health since 2017. He is a NABH assessor from 2009 and the first NABH assessor at South Tamil Nadu. He has been awarded with many awards as Outstanding Anesthesiologist of India for the year 2010 by Indian Society of Anesthesiology, awarded Medical Entrepreneur of 2018 by Indian Medical Association, is a certified assessor in NABH, and he has been awarded Best Doctor Award 2012 in Tamil Nadu, Dr. MGR Medical University, Chennai. I am so privileged and honored to welcome Dr. Manivannan Selvaraj. Thank you so much. It's a great honor.
Thank you.
Over to you.
At the outset, I'd like to convey my sincere thanks to the organizers of this conference. Something very unique. Normally, I haven't spoken in an industry conference like this probably once, 6-7 years back. I need to thank the industry forums, because 10 years back I learned about 5 years on lean in one such forum. Then I got interested, and we have taken it forward in the last 10 years, and we have learned a lot in the journey actually. I'm here to share with you about our experience in healthcare actually. Probably we learned most of the things from you, and probably you'll know why it is beneficial and need of the hour for the society. That's the primary aim of this talk. See, Kauvery Hospital, there was a little bit of a change in the numbers. We started with 30 beds in 1999 in Trichy. We are first generation doctors and first generation entrepreneurs. So the doctor profession was new to us, business was new to us, but we straight away jumped into sea and started learning swimming. That's what I keep telling. And from there, we slowly grew up, and from Trichy we moved to Chennai way back in 2011. And then now currently we have 8 hospitals in 6 cities. We have 1,750 beds. Probably next 2 years we'll be adding more beds and reaching 3,000 beds. And more than that, say we have more than 5,500 employees working with us, more than 500 very highly qualified super specialist doctors associated with us for a very long time. And of course the core nursing, we have more than 3,000 nurses working with us. This is briefly about us actually. So this is our vision to make, to be the most respected and trusted healthcare provider. Say we all know that unfortunately for reasons which may not be right or wrong, the corporate healthcare, many people do not trust corporate healthcare, where in industries if it is or other places corporate is considered as a good word, good performance, whereas in healthcare corporate is considered as someone who is fleecing the patients. But so we wanted to build and bring back the trust actually and respect which we duly deserve. And the mission is to make great healthcare affordable. That's also very interesting, where great healthcare is something where world-class treatment, the high-end procedures, high-end therapies, and also less waiting time, good customer experience, and also affordable actually. Affordable doesn't mean that for everyone. It's very difficult in private sector, we all know, but affordable to our target population. That's what makes us what we are today. And this lean journey, especially our 5 years of lean journey, helped us to build a great healthcare and affordable healthcare. It's a journey. We have not achieved it. We are working towards it. And of course, the value systems which brings in all the employees together is, we call it CHEERS actually. Continual improvement, hard-fed percentage, ethical, empathetic care, real accountability, and service excellence. Each and everything is very important, very core. We formulated this 10 years back. We had a discussion with all our senior executives, doctors, employees, and then ultimately we brought down a simple terminology, which I can proudly say that 95% of my hospital employees can tell what is the mission values, and also tell what is the basics behind that actually. So now today I will cover briefly about what is healthcare, current scenario, past, and then what is the difference between Indian healthcare and Western healthcare, why waste reduction is important in Indian healthcare, and what is our experience. This is what briefly I am going to cover. If you take healthcare in the past, as you all might be knowing, see those days a doctor will after graduation will come to the native town, start a small hospital, means, or a small clinic with a OPD. Mostly it is a outpatient based treatment. 1 or 2 small hospitals were there. The cost involved in setting up such practice was less. There was no improved diagnostics were not there, no CT scan, no X-ray, nothing was there. And the complexity of the disease also was not there. Now we have got a lot of lifestyle diseases. Because of that, diabetes, hypertension, we get all complex problems. So past was actually easy for everyone, including the patients and doctors actually. The investment was less, cost was very minimal actually. But what is the present? Currently, we all know that lifestyle disease like diabetes, hypertension has led to multiple complex diseases like heart disease or cancer. So many other things have started coming in which our parents or grandparents never saw actually, never heard about it. And one of the reasons is also improved diagnostic. We started getting a lot of X-rays, CT scans, or so many other investigative methods come which diagnose, pick up all these diseases at an early stage. So because of these two factors, the healthcare is not simple as it was 30 years back. Now healthcare has become a complex ecosystem, complex structure, where we have a multi-specialty hospital where 5 to 7 or 5 to 10 super specialists manage a patient, where we have ICUs with all complex gadgets or diagnostic equipments to detect and also complex operation theaters where very high-end procedures are done. So currently it has become a complex system actually. So naturally when it has become complex, cost has gone up actually. And one more interesting thing has come currently is a lot of insurance patients have started coming to us. Earlier insurance was not there. Today when we started our hospital, only 5% of our revenue came from insurance patient. Today 60% of our revenue are coming from insurance patient. We expect that to go down to go up to 90% of the patients will come from insurance. What happens when insurance comes? Insurance controls the cost actually, okay, because earlier because of the demand supply gap, whatever the hospitals were charging, the patients had to pay. If they can't afford, they go to government hospitals. But currently, because of insurance, when an insurance patient comes to the hospital, we need to adhere to the tariff, and insurance cannot be providing. All the insurance companies, especially healthcare insurance companies, are bleeding actually. So that's a problem currently because the premium is low, the coverage is very less, and they are bleeding actually. So going forward, we feel that 90% of our patients will be insurance patients, and the cost we have to cut down necessarily out of compulsion we have to do. So the future of healthcare is probably the complexities may be increasing, but use of technology and other things will improve the services of the patient, as we have seen during COVID where teleconsultations were there. People sat at home and doctors at the comfort of the home, they started consulting and people need not travel. A lot of things started happening from home collection of blood, x-rays, or so many things have been started doing in home collection. Now currently we have some services like home ICU where someone who is really sick but don't want to get admitted in the hospital, the similar ICU setup is done at home. So a lot of things are going to happen in the future and technology will play a role, and of course cost also may increase a bit, but a lot of other convenience will happen, and of course insurance patients are going to increase, and that's going to be a challenge for us in a healthcare organization. It's good for the consumer having an insurance coverage. Western healthcare and Indian healthcare, there is a lot of difference. People always compare. I mean, we should be right. That's what we learn from automobile industry. The same world-class Toyota car we are also driving. The same Mercedes-Benz car also we are also driving. In fact, Suzuki car came at a very affordable cost. Indian Maruti Suzuki came. But can we do the same thing in healthcare? Actually, can we replicate the same thing in healthcare? Can we have the same kind of quality of healthcare in India? So immediately people will think that Western healthcare is very good, Indian healthcare is bad. But I'd like to say one thing, that Indian healthcare, especially in developed states like Tamil Nadu and other places, the healthcare is far superior than Western healthcare. I would like to say that. Because far superior, because I'll tell you my personal example. My brother was, thank you. My brother was in UK, he's a doctor, orthopedic surgeon, he manages the Chennai region, Dr. Aravindan. He was in UK for 15 years. So once he had a problem, he had a small headache which he couldn't tolerate. He went to his own hospital. He had to wait for 6 hours in the emergency to get a doctor consult and a treatment actually. 6 hours he had to wait actually. And they asked him to take an MRI. You will not believe the waiting time was 8 weeks actually. So you believe he flew down to Chennai, took an MRI, went back actually. Okay. So today, Indian healthcare system in at least certain developed states like ours is amazing actually. It's amazing actually. But of course, a lot of technology developments or new innovations happen in Western countries because of their innovative culture. We do not have that actually. We do not publish our findings also, unfortunately. But slowly it is improving. But still in those areas, innovations, Western healthcare will be better. But this is an article which I read just 10 days back after being invited to this. I just saw this. It came in our hospital, my classmates group. So waste in US healthcare system is amazing. You'll not believe that 28% of GDP is spent by America on healthcare. Okay, 28%, out of which 30% is wastage. Somewhere around $600–700 billion are wasted every year on overproduction or whatever in your terminology. I'll just come back to that actually. So this is what the healthcare spend actually. If you see that We are currently somewhere around 2.5%. Actually, we have been slowly improving. We are better. We have doubled in the last 15 years. But American healthcare system, if you see that 19 or 20% is what their current thing. Sorry, no, I said 28. 20% is what, and it has been like that for the past 30 years actually. They are spending so much on healthcare. But currently at least current mindset will not believe that currently all the politicians are really happy with the political discourses happening in this country, because people started focusing on healthcare. At least in Tamil Nadu, I have seen, when I haven't traveled much outside Tamil Nadu, I have seen the last 15 years, any government which came invested in public healthcare. That's why our public health system is one of the best in the country. And but this we see in pan India. That's why we see government coming out with the Ayushman Bharat scheme, or digital health mission. So many things are coming. Down the lane, probably from 2.8 to we'll go to 5 or 6%. If we go there, then that's amazing. So since government is spending very less, more than 90% of the treatment, 80% of people pay out of the pocket for healthcare. We have heard stories where families have become bankrupt because of one healthcare admission actually. We have seen people who get retired, get some retirement money of 5 lakhs or 10 lakhs, they put in the bank, save for their children's marriage or education. Suddenly he lands up in diabetic and with sepsis and ICU. 10 days later they see that the entire savings are gone actually. So out of pocket expense is extremely high. That's making people poor actually. There are two things which can be done. Government can invest a lot in healthcare, like what European countries have done. It's a social system which is amazing in Europe or UK, where healthcare is free to most of the 90% of the people, and that's world-class healthcare is free because they are investing heavily in public health. That can happen in India, but it may take a very, very long time, not in a near future. Then what happens? Private sector plays a major role. When private sector plays a major role, it's the duty of the private sector to reduce the cost as much as possible. It's impossible to reduce it very significantly, then the quality suffers actually. So it's the private sector's duty to reduce the cost of healthcare actually. So that's the reason why I put this, because in near future also we don't expect more than 5% of GDP being spent on healthcare. So that's why I said in near future, even a 70% of people is going to pay out of the pocket, out of which only 50% will be having insurance, remaining 50% will not have insurance, then that becomes a big problem as a public. So contribution to the society, we need to reduce the wastage in healthcare. But I can tell you some examples also. For example, you take a bypass surgery. I was just talking in one of the conferences where Western delegates were there. It's a healthcare management conference. I was just telling them that, say, we do bypass surgery in this country, in our hospital, for $1,200 actually. He said $1,200 for bypass surgery. I said, yes, if you take it in today's rate, it's only $1,100 actually. So 95,000 is what we do bypass surgery in a government insurance scheme. Of course, for a cash paying patient, it could be 1.5 to 2.53 depending upon the category of room they take actually. But for 95,000 rupees, which is $1,100, we do a high-end bypass surgery in our hospital. The surgeon is internationally trained. It is not an ordinary surgeon, internationally experienced surgeon. The mortality rate results are at par with any international organizations. So we have reduced costs to a significant level already, but there is also a room to reduce further actually, but not to a rock bottom price. So this is what is Indian healthcare is actually. Of course, see, we operate on high-end procedure which may be costing in lakhs and lakhs of rupees, but that's different for different segment of patients. But 70% of my cardiac surgery, cancer surgery in tier 2 town like Trichy and other places are done under government insurance scheme actually. Tamil Nadu has got a good public-private partnership where private hospitals are enrolled for tertiary care, which we do kidney transplant. Last year we did 110 kidney transplants in Trichy, out of which 95 are government insurance scheme, free of cost to the patient actually. So this is what Indian healthcare and Western healthcare differences. What are the challenges we recently faced where forced to look into our cost systems, and I said that government insurance scheme in 2006 or 7 when government came into healthcare sector, public-private insurance partnership came, they introduced the government insurance scheme. At that time, there was a significant reduction on the payout, more than 50% reduction. Then we seriously started looking into our consumables, the cost, the duration where surgery is done, the complications, all those things we started looking in, cutting down the cost, and it has reduced the overall cost significantly, which I'll come later. And of course, COVID was the biggest challenge. COVID was the biggest challenge because we didn't know what COVID was, and we didn't know what treatment to do, and the cost was jumping very high. All of you know that there were a lot of complaints again, hospitals were charging high, but government came up with a tariff structure, and we're one of the very few hospitals we wanted to adhere to the tariffs, actually government tariff, but still we made a good profit. I'll tell you later actually. So the another thing is these challenges is resource optimization. Of course, resources means there are critical resources like doctors and nurses are my critical resources. It's very difficult, at least in southern states where a lot of medical colleges are there, we get good quality resources, but North Indian states are just now picking up a number of medical colleges, getting quality resources. See, quality resource means I can say that I have a, say, hemato-oncologist in Trichy. Hemato-oncologist means who treats on a blood cancer. In Trichy, I have 2 people, one adult, one pediatric hemato-oncologist in Trichy. Surrounding 8 districts doesn't have anyone. And we treat close to 40 to 50 patients on blood cancer in Trichy, actually. Imagine getting this particular resource to Trichy. It is such a challenge. Probably such resources will come to Chennai or Bangalore or Delhi or Mumbai, but getting them to Trichy is something which is very important. And how to retain these people actually, and how to make their work efficient. Okay, there is a lot of demand for this particular specialties, and I need to optimize, and I need to have critically ill, critical care trained nurses to do that. And doing that in a tier 2 and tier 3 town is the biggest challenge actually, where we do a lot of training of employees and how we can cut down costs by developing our own internal resources. We have a nursing college where we produce around 400 to 500 paramedics every year. So we train our own people. In that way we cut down cost, and so that people from rural areas, students become the critical care doctors or critical care physicians or nurses actually. And of course, I've said the GDP spent by the government is the biggest challenge actually. But all these things, what happened over a period of time in the last 10 years, at least our experience is, as I said, the future is going to be technology, not primarily technology driven. Technology will aid doctors and patients. But in the last 10 years, what happened, we started doing a lot of automation and analytics. So we have robust ERP systems. Earlier ERP systems are only in manufacturing industry, other industries. We started having good ERP systems. So we started collecting data, and with data analytics, we were able to understand that, okay, which is the top 10 drugs used, which is the top 10 investigation used, why the cost is there. Can you use the Pareto's principle, cut down the top 80% cost? Can we do those things? That's what we started doing it. These kind of analytics helped a hospital like us to really identify high cost items and cut down the cost. And of course, this is our journey. 5 years we started way back in 2009 and 9. I remember in a conference, in a healthcare conference, I gave a lecture, and after giving a lecture, I was just sitting there. The next speaker was talking about lean management in healthcare. He spoke about lean management. I didn't understand even a single word out of it actually. Then when he came down, I asked, sorry sir, I didn't understand anything what you're talking about. In 2009, huh? Okay. That's what I keep telling that at that time, 2011, when we started reading about quality and a lot of internet awards and other things, I was reading about Deming. First time I heard about Deming was 2011, okay. Then I was reading, I saw an organization in Trichy got Deming Award in 2002 or 3, Rane Industry. I'm basically from Trichy, and there is an industry which got Deming Award in 2002, whereas I came to know about the word Deming in 2011 actually. That's a sad part of it. But from that particular speaker, I learned about lean healthcare. He recommended a book on lean healthcare. I learned in the book and started implementing some basic 5 Is principles in 2009 and 10. And later I happened to attend one of the CAA conference on 5 Is for industries. I was the only non-industrial person, only person from healthcare, and luckily got a mentor out of it. And then with that mentor, we started implementing 5 Is practices across Kauvery group. And over a period of time, a lot of implementation challenges were there. And now we are reasonably mature organization in 5 years and lean practices. In fact, next year we are applying for model company for 5 years. One of our Trichy units applying for model company for 5 years. That's our brief journey. And in this journey, we have learned a lot from reading books, or when we participate in some competition or award, we learn a lot from industries like you. So these are something which is very critical. Wastage means, when I was talking to my colleagues and my doctors, I said, I'm going to talk about waste reduction in healthcare. They said, are you going to talk about reducing plastic waste, reducing biomedical waste? I said, sir, that is not waste we are going to talk. This is a different waste actually. So, something which whatever I had a limited knowledge, I started discussing about what is value added activity, what is non-value added activity. And we have one Mr. Dhanashekhar who heads our business excellence here. He came from manufacturing industry. So what we did was, when he came for interview, 4 candidates came for interview. I made them to do health checkup in the morning, okay, in our hospital. I said, we'll pay, don't worry. And I said that at the end of health checkup, you have to give us a presentation on what is the improvements which we'll do. And probably Dhanashekhar is the only guy who had put value added, non-value added. Doctor, I spent 6 hours in this hospital, out of which only 40 minutes were value added, remaining 5.5 hours are waste actually. So I said, okay, come join us, you correct it. That's what we have put on actually. So he has joined us and he is here to finish it actually. So the waste reduction is different actually. Waiting time is one thing, obviously. Here, you see this mortality rate, post-operative death, re-surgery, surgical site infection, hospital-acquired infection, medication error, antibiotic usage, bed sore. I've just taken few indicators. We monitor around 70 clinical indicators, out of which key things which you will be able to relate to us. For example, a patient coming for some admission, of course, we have a mortality rate of 2 to 2.5% in critical wards. But patient should not die for reasons for which he is not admitted. Very simple. Patient came for some kind of a cardiac surgery, but he is dying out of infection. That is wrong. That is actually waste in the system, waste for the consumer actually. He is paying more. For example, antibiotic usage. When they all say that all of us pop some antibiotic, azithromycin, when we have fever. But similarly, we use antibiotics, empirical antibiotic usage, we cut down actually, because we have significantly cut down our antibiotic usage, which will reduce the cost to certain set of patients by 25%. 25% means that could be more than 15,000 rupees per day. The cost can be reduced to a patient by cutting down the antibiotic usage. Or for example, bed sore. You will not know, we think that patients, our old grandparents, when lying in the bed in the house, they get bed sore. No. When patients coming to the hospital very sick, lying in the bed for 10 days, most of them develop bed sores, which we have seen 15 years back. Because of bed sore, he will not be able to discharge. Some patients have died because of bed sore, not because of the condition he came for. So that is the waste in the system. We are wasting the money of the patient. And another interesting thing is, I don't know whether I have that slide. Another interesting thing is average length of stay. We calculate the average length of stay for a patient. That's called ALOS actually. We know that for bypass surgery, the patient can stay for 6 days. For a laparoscopic gallbladder surgery, patient can stay for 2 days. This is what he has to stay. Beyond that, he should not stay in the hospital. If he is staying there beyond that, then what happens? It shows that, excuse me. Yeah. If he stays beyond those 2 days or 3 days, then that shows that patient has got some infection. For some reason, he is staying for longer days. If he stays for 1 day extra in my ICU, the cost is around 20,000 rupees. Suppose patient develops some complication or allergy or some drug related thing, and he has to stay for 2 more days, that's 40,000 rupees actually. And imagine, our ICU is almost always full. I'm having one patient who was supposed to be discharged yesterday, but he is staying here for some bed sore or infection. I'm not actually able to get a deserving patient inside. That is actually wastage in this. Optimizing the resource. I reduce the length of stay as much as possible. With available 200 beds in this place, I can have more patients treated actually. So that's where waste reduction happens. Suppose a patient develops a surgical site infection after surgery. Imagine, we are going to give him antibiotics, he is going to stay for 4-5 days and he is going to occupy a bed. It is wastage to the hospital, wastage to the patient actually, which is not acceptable actually. These are some indicators which we see wastages actually happening. This is where our focus is actually, our focus, since I was an assessor for National Accreditation Board for Hospital for 10 years, I've assessed close to 100 hospitals. Actually, I learned best practices from many big hospitals and then came and implemented. I was able to see practically what's happening there. Implemented a lot of these best practices, and the results I'll show later. Cost of poor quality. Someone said, they keep asking, should we invest so much in quality? Then you need to have someone like Dunshaker from industries, and you should have quality head. We need to go for accreditation, and we need to pay accreditation fee. Why should we do all these things? You are adding to quality, and we have to do some documentation, and paperwork is increased. This is all increasing the cost. We should understand cost of poor quality. This particular news, probably people in Tamil Nadu would have read about it. A few weeks back, a young footballer who had a knee injury got admitted in a government hospital. She was operated, surgery was successful, but they had applied a tight bandage and they haven't seen it. So next day, the entire lower limb got gangrenous, necrosed, and the limb was cut, amputated, but 2 days later she died actually. But Tamil Nadu government hospital, man, I should say that here, disclaimer, are doing amazing job. But one single incident has spoiled, taken a dent, reputation has taken a dent, which is unfair. So we can't afford to make even a single mistake. I mean, we know what Six Sigma says actually. For when Six Sigma, when I had underwent quality training, one of my teachers said, Six Sigma, understand the importance. He said that, see, the nearest in our evolution, the nearest thing is a monkey actually, for human being actually. He said the genetic difference between a monkey and a human being is similarity is 99.99%, 9% actually. 0.1% difference makes it a human being or monkey actually. So here 0.1% could be the life and death of the patient actually. So that's why we can't afford to make any such mistakes. So such mistake cause huge reputation damage to the whole industry actually. And of course, these are the ways of lean healthcare. If I'm crossing the time, please alert me actually. So, see, these are the, I've heard this, and my colleague showed me about the transportation, inventory, motion, waiting, overproduction, overprocessing, defects, and right utilization of talent skills. So Tim Woods is what, see, it is relevant to us actually. See, transportation, actually, see, it's all, we all knew that this is happening. We didn't know that how to categorize, and we learned from the industry how to categorize so that we'll focus on the change corrective action. See, a lot of patients get, in fact, transportation, if you see that, and motion also, the patients are shifted from, say, in fact, when he went for the health checkup, they have to go to 2 floors above, 1 floor below, 3 floors. A patient has to move to so many places actually. In fact, we had put one pedometer on my nurses and found out that how many hours, how many kilometers they are working. Walking in the duty, 8 hours duty. You'll not believe these girls, young girls, puny girls were walking for 3 kilometers or 4 kilometers within that small span, going from here and there, here and there. Actually, we did a very interesting project to reduce this motion, where we found out that most of the time when there is a nurse bell is buzzed actually, the patient wants to have, I need an extra pillow, I need a coffee, I need this food. It's not that nursing care or medication, they were bothered about this. So we had a dial 24/7. There is a program where the patient can, from intercom, he dials 9 or something. Someone picks up order, I'm calling from 222, I need a pillow actually. Okay. Then within 10 minutes the pillow is delivered actually. So 80% of this movement got reduced because of that. We put a pedometer and found out that. Similarly, inventory. Inventory is huge, but we were not measuring inventory 15 years back. We started measuring inventory, we found out that huge amount of inventory is wasted. It's a debt capital which we are getting loan at that point of time, 14-13% interest rate, but all those things are wasted as inventory. Now our inventory has cut down significantly. In pharmacy, when we started this practice, there were 45 days of inventory was there. Today is only 14 days and on average inventory is there. Inventory cost is, debt capital is reduced actually. And also waiting. Waiting is a huge problem. If any of you have visited a hospital, you will know that you have been waiting in the door. Though you got an appointment, you are waiting there for 1.5 hours. After discharge, you are waiting for 3 hours to get discharged or bill to be ready. It's very difficult. We are still work in progress. We have not completed it. But that's our major problem which we want to address actually. And of course, defects. Defects in manufacturing sector, if it is identified, can be thrown out, and or if it is not identified, you know what is the cost of recall of all these cars and other things. It's very dangerous. I can't recall here from heaven, actually, unfortunately. Okay, there's no room for defects, actually. And of course, skills is something which we call de-skilling. Say, very important, my cardiologist time is very important. Very few cardiologists are there, they're busy. Earlier, they were doing all this echocardiogram and other treadmill tests. We trained physician assistants to do all those things, so that today in our hospital, none of the cardiologists are doing these tests. Physician assistant does it. If there's any problem, cardiologist helps. So 50% of their time is actually utilized in seeing the patient. This is what we are trying to do. And of course, in the next 2 weeks, we are going to introduce a digital ICU where all our monitors, everything will be connected to our ERP systems. All the pulse, BP, everything will be noted. Currently, nurses are writing. At least 2 hours in their duty is used for writing, which we want to reduce it. So, manufacturing industry and healthcare industry, there is a difference. Obviously, I said that a car can be recalled, but a dead patient cannot be recalled, actually. So, I'll tell you a joke, actually, which my cardiac surgeon keeps telling. So, cardiac surgeon went for, he has got a Mercedes. He says, I went to give the Mercedes for a workshop. And that guy suddenly said, 50,000 or 75,000 is the charge. He said, boss, why is 75,000 for this? Sir, you are a cardiac surgeon working on the heart. I am a mechanic, I am working on the engine. So, that's the same charge, sir. He said, okay, you also repair when the engine is running. Then I'll pay 75,000 rupees. Because I operate the heart and it's running. Okay. So that is the difference between these two industries, actually. That is the difference between these two industries. And of course, but good things can be replicated, but that's the difference. So I was talking about, well, I'm not going to details into what we have done or how we have reduced cost, because a lot of activities are happening, which I have highlighted few things you can relate to. So what happened? During COVID time, as I said, we were adhering to the government tariff. We have investors on board. We have 2 investors. So we have a really strong board, corporate governance. So many things are there. They keep asking, what is the business results today? When all those things they keep asking, actually. Of course, I have to pay back them. I have to take care of my patients and doctors as well. So during COVID, what happens? We were adhering to government tariff. But you will not believe, under COVID first wave, and that particular year, our investors were a bit anxious during COVID, because initial few months the hospitals were running only 50%. Later, of course, it was busy. At the end of the year, our investor only sent a report stating that Kauvery hospital, our hospital, had the maximum EBITDA in the entire country, actually. Our EBITDA percentage was highest in the entire country. Of course, today the other hospitals have taken over. But during COVID, even during COVID, we are cutting down cost, but still adhering to government tariff, but still had the highest profit margin, actually. Okay, so this is what I call the business result out of waste reduction. I'm answerable to all the stakeholders, let it be investors, banks, my doctors, nurses, and my patient. I'm answerable to everyone, actually. And I can say that in the last, say, 6 years or so, you know that inflation rate is high, the cost is high, HR cost has gone on, consumable cost, electricity cost, so many things have gone up. Average tariff increase in our hospital was 2.2%, actually. Average tariff increase was only 2.2%, because we couldn't afford to increase more. It's only 2.2%. But you will not believe, in the last 3 years, and even in the pre-COVID 3 years, our turnover was doubled, more 120%. Our profitability almost 130% more than 3 years back, actually. Okay, that is the truth. That's why we have got one more set of investors who are valuing us very high, because of our operational efficiency and improved results, actually. Okay, so this is what the business results out of all this activity. And of course, in this journey, we got a lot of awards. The first time I got motivated was when I came to an award function 10 years back to a CAI, where I just wanted to learn 5 years. I brought in my team members, and I saw a presentation from mills called Jayajodi Mills, actually. Jayajodi Mills, they presented, the girls were all young girls, 20, 21 years old. They presented amazingly well. And I got so thrilled. In fact, after that, many times my team has visited Jayajodi Mills to learn from them. And all these award functions or whatever it is, helped us to learn from other industries or motivate my staffs to do more and reduce costs and contribute back to the society. And with that, my sincere thank you for the industry for teaching us what Lean and 5 years is all about. And I was just telling, just briefly before the talk also, that I think, say, today, when I was hearing that most of the Deming Awards are in South India, and Tamil Nadu industries have got that quality award. It's the duty of the industry to educate healthcare on waste reduction. And of course, we are also doing on our part on educating our fellow colleagues. It's the duty of the industries to educate healthcare about waste reduction, and ultimately, it's as a community, you are the one who will get benefited. Thank you all.
I only have one word for him, OMG. This is phenomenal. I mean, it's so inspirational. We are typically used to, words like paracetamol, antibiotic, analgesic, things like that from doctor. But a doctor saying and talking about lean, Pareto, waste, and all those things is simply unimaginable. Thank you so much, Megan Indri. Thank you very much. May I call just one moment. May I call Mr. Thomas Matthew to be on the stage to, express our deep sense of gratitude towards Dr. Manivannan. And I'm sure that if somebody can help us with, and I'm pretty sure that our seniors from Indian Society for Quality have taken a note about having a collaborative effort between healthcare and industry. I'm sure that we will, it's a wish that we can see some kind of initiative between the healthcare sector and the industry. But thank you very much, Megan Andre, again.